Oh,
Okay.
Like I just kept hearing the replay. So I don't know if you talked about doing it a certain way or whatnot.
Um, well, basically, I think that I interpreted it a little bit different, but I'm good to go whatever way anybody wants to
Yeah.
do. But I think I'll just read the blurb here, and then what unless anybody has an issue with this, what I think that we could do just to cover all of our bases is I'll read the blurb, we'll all kind of answer the questions together, cite some information, and then do kind of a short roundtable. Thoughts?
About
sounds
each.
good. Go ahead.
Sounds good? Okay,
Sounds fine.
Are
cool.
we are we giving research references in regards to each question? Because I only really responded to the second question. I didn't read.
Oh, good point. I only have like a thoughtful response to question 3, but I will chime in on everyone else's questions as best I can.
No, that's fine, as long as we have something to reference with every question. So I can kind of go through the first question, and then from there we can just have some discussion, I think, on it, and I think we should be fine.
Okay.
Okay, we can try that.
So before, in case anybody knows, so after this closes, does anybody have a concrete answer as to where the link is, so that we don't lose our information? Because when I've closed these, I can't always find the link.
Okay, I know that when I closed these and I went back to Google Hangouts,
Yep.
you see the little alarm or bell or whatever. It
Okay.
has like a 1 or 2. I'll click on that and I'll see, do you want to watch this? And it's the past one we were doing.
Okay, cool.
That, and then, well, what I said before, maybe you, probably on YouTube, your YouTube, you'll see it.
Yeah. Okay, sounds good. All right, so I'll start. So our assignment is the patient has been admitted and had been found in his home by neighbors, lethargic and unable to communicate, but he has his license with identification. The EHR identifies him as Mr. Kenneth Lister, who has multiple comorbidities, diabetes, heart failure, with an EF of 30% and a history of cancer. He was last admitted to DRHA in 2011 for a successful angio, but following the procedure, he had recurrent events of hypoglycemia despite many years of well-maintained blood glucose levels and experienced a fall while trying to get out of bed. It is unknown if Mr. Lister has had any recent admissions to other hospitals or procedures since 2011. He is currently in ICU with a blood glucose of 350 and a highly irregular heart rate. The plan is to send him to a medical unit once he is stabilized. The nurses in ICU have been recently trained and are using an intensive insulin therapy, or IIT, clinical decision support system, CDSS. The IIT CDSS is new to the ICU and can provide tighter control of blood glucose levels. However, the medical unit does not yet use IIT CDSS. Discuss our answers to the following questions. So, the first question is, how will you as a nurse leader integrate the IIT CDSS into your unit's practice and effectively communicate the changes to all the members of the healthcare team? So, as a nurse leader on a medical unit trying to educate the staff and sell the information about the new process change and how it's been working in the intensive care environment, what initially I would first do is I would work with the team, probably with an educator, work with whoever was in the ICU, whoever developed their initial program, try and find out kind of where they were coming from when they started it, what the rationale was to begin a change, where the research showed that it was beneficial to the patients. In doing so, there's going to be, with any change, there's going to be a lot of pushback from more veteran staff especially. I think in doing so, one of the things that's mentioned in our textbook actually is a CDS best practice, and basically it's the 10 commandments for effective clinical decision support, making the practice of evidence-based medicine a reality. So just kind of this kind of, I think, highlights some of the barriers that you'll face when implementing any kind of a CDS change. So there are 10 things here, and basically it says that speed is everything, anticipate needs and deliver in real time, fit into the user's workflow, which is obviously really important. Little things can make a big difference. Recognize that physicians will strongly resist stopping. Changing direction is easier than stopping. Simple interventions work best. Ask for additional information only when you really need it. Monitor impact, get feedback, and respond, and manage and maintain your knowledge-based systems. So that's taken out of the textbook. I took it out of Nelson and Strager's 2014 Health Informatics. Basically, the way that I see it is when you're implementing this, going through these top 10 best practices is that you have to ensure that whatever you're going to implement is going to fit into the workflow. So getting the feedback from the staff when you're about to make a change is really important. Having them have a voice and share what they believe the impediments to actually implementing it would be and what they believe the benefits could be so that they can develop the program themselves. It's going to have a much better likelihood of success if it comes from the people that are going to be using it and not kind of as a top-down change. I think I can stop there. Thoughts?
I think you've made a lot of great points.
Mm-hmm.
Yeah. I think it's important when you're implementing change in a nursing unit that the staff finds out from the management first rather than hearing it through the grapevine, or I've just been through a lot of changes in different places and hospitals where you get wind of the change, then management tells you later and everyone's already soured against it. So I think once they knew the intensive care unit was implementing this, that maybe the managers on the other units could already have met and thought about how they're going to roll it out hospital-wide and introduce that idea when the intensive care did it. That way everyone in the hospital knows, hey, this is coming along.
Yeah, good point.
Agree.
Cool.
Yeah, there's been many times where you walk into work, like you said, Joey, and there's a change and you don't get word of it until later, and you might not even agree with it, but there's nothing you can do. So I think it's important to ask the staff before implementing a change, what their thoughts are, and obviously education is important. So.
Yeah, no, I totally agree. Asking their opinions, asking them to get involved in what's going to work best and what they might find to be troublesome in their workflow will definitely make them more likely to adapt the new change.
Awesome. Okay.
Okay, I had question 2. It states, why would a nurse choose to override the CDSS, and how could this be prevented? And basically, in my reading, the article in the Journal of American Medical Informatics by Thomas Campion Jr., 2011, it stated there was a study conducted at Vanderbilt University Hospital on an intensive insulin therapy clinical support system on an ICU unit, and a lot of the nurses who were choosing to override the system chose to override it because they felt the recommended insulin dose was too high, and they were too afraid, basically, to drop the patient's blood glucose level. That was one of their main concerns. The nursing staff obviously wasn't educated enough, I think, on the algorithm and how it presented the dose appropriately. Let's see. Prevention, obviously, is, like I said, education. The nursing staff also found a problem with the charting system. They were having to chart their doses on a different system, which took a lot of time from patient care, it stated. So I think all of that, it's important to look at if you're going to implement a change. Look at certain studies and see what worked best and what didn't, and making those changes.
I think you hit it exactly. I think those are the two things. Doesn't matter what you're talking about. If you're talking about like a PPID type thing where you're scanning for medications, you're talking about anything. Nurses sometimes have resistance because it slows down workflow they perceive, and especially with changes with medication type protocols, sometimes people that have been around for a while feel they're unsafe, or they just don't know what to expect, I think. So just kind of again, touching back on education and talking about and reinforcing why all of these technological things and advances, I guess, are going into practice. I mean, really reinforcing, that 100,000 people are dying, or even that's even like a decade old, I think, that figure, but 100,000 people a year just from medical errors. So.
Right, and the study did say, like 95% of the nurses did comply with the system, with the recommended doses. But they found that, the nurses who were overriding obviously weren't giving enough insulin. And so the patients were suffering from that. They were having higher blood levels,
Right.
which, can cause harm to patients. So.
Right. All right.
Okay.
Who's on 3?
Oh, that's me. So, I looked up some information about the use of smartphones and tablets and how they can help communication through the hospital between all the team members. So the first thing I looked up was the article by Anita Moore and Kathleen Fisher from 2012 in Computers, Informatics, and Nursing. And in there they talk about how HIT includes the technology used to communicate within healthcare. And for me, that specifically addresses whatever the intra-facility communication tool is. So, traditional sense, you're thinking of a paging system and hardline phones, but nowadays you are talking about really the use of smartphones and tablets, something other than a beeper. I worked at a big teaching facility back in Iowa where we implemented using iPhones throughout the whole campus, and what they did was purchased iPhones, stripped them away except for the calculator and clock, and then they purchased an app called the Volt app that functioned. It looked like you were using the phone, but you were just using their app to communicate with each other, and it was super efficient. I miss it very much since I moved to Arizona. But it allowed you to call and text directly anyone you needed to. So what this article does say about different technology coming in is that they're expensive, so it's going to depend on what funding's approved and what you're willing to spend to increase communication throughout your facility. I also read Charlotte Seckman's 2014 article in Ramona Nelson and Nancy Stagger's Health Informatics text, and in there they talk about a couple of issues with regards to new technology in healthcare facilities. The first was the privacy part. So as you introduce all this new technology, you need to make sure you have your privacy, HIPAA, all of that stuff. It gets more and more difficult to control, so you have to have a way to communicate to the staff of how you're tightening all that down. And then they talked about disruptive technology, which it's something that completely changes the way traditional healthcare is done. So they're not paging and answering a landline. They're using their smartphone, texting from it. That's changing the culture. So it's gonna depend on what the people that are using it feel about it. So if you have a nurse that's approaching retirement that maybe has a flip phone or doesn't have a cell phone, they're going to have a little bit of resistance to it, so you have to be prepared for that. And then the last article I looked up by Laura Egerson in 2012 from Canadian Nurse, she wrote an article about the use of smartphones and tablets in both nursing education and in the professional role. The barriers that she identified were, again, the privacy policies, and then management was another barrier because once they were using their tablets and phones, both management, administration, and families and patients thought that they were using the phones for personal use when in fact they were using it for the job. So that's going to be a barrier in itself, letting people know, hey, we may have these iPhones, but we're not using it for us, we're using it for you. So just to end it, I think that it's a great tool. I think hospitals need to implement them because that's just, we all have 15 different devices that we're using. I mean, right now I'm on my laptop, I have my iPad next to me, my phone's right here. So it's the way to go.
Yeah, I agree.
The end.
The end.
Okay. I'll start with my question, which was question number 4, and The question goes, are there any other technological devices that may help with the transfer of patients between the emergency room, ICU, a medical unit, and then discharge home? So, I'm just going to kind of read off what I wrote. Technological devices that may assist with the safe transfer of Mr. Lister from one unit to another, then home, could be the following. The use of electronic health records, other informatic tools such as a handover risk assessment tool, patient portals, and patient electronic devices like their handheld device, their cell phones, their iPhones, or their personal computers at home. These tools can assist communication, coordination, and patient safety. So one of the articles I read has a lot of authors to it. Sider, Miller, Jensen, Bingtug, Wolf, 2011, The Role of Informatics in Promoting Patient-Centered Care, from the Cancer Journal, just talked about the use of electronic health records are a very important technological tool that can enhance patient safety, efficiency, and patient-centeredness. Then another article I read, more, 2012, the European Handover Project, The Role of Nursing, talked about the handover risk assessment tool, and I hadn't heard much about this, and when I was in the hospital, we never used anything like this. Basically, it's a standardization quantitative handover risk assessment tool that determines a patient's level of risk for poor outcomes during a transition. The handover risk assessment tool has the potential to improve handover outcomes and assist the health team in using their time in an efficient and effective manner. The next one was about patient portals, also from Snyder, Wu, Miller, Jensen, Bingtug, 2011, The Role of Informatics in Promoting Patient-Centered Care. They talked about the system allowing the patient to access their own medical information and communicate with their healthcare team. Studies have shown that patient portals are useful tools for patient interventions by allowing patient coaching and education, which can focus on their chronic health condition. And then the handheld devices or computers used by patients and their families, they've been shown to be an efficient form of communication with the healthcare team and the patient and their families. The overall literature suggests that the utilization of these kind of technological, I don't know, I can't talk today, sorry guys, support system has improved chronic disease outcomes, and that was from Moore, the European Handover Project, 2012. So the use of these tools, I feel like, have a significant impact on the patient outcome and also their satisfaction. The patient portal, patients reported feeling like they were receiving better overall care just because they had that direct communication with their provider. Also allows the healthcare team to kind of utilize the patient information, can positively impact their safety, and it also allows them to focus their energy in a more effective manner. So that's my spiel.
Awesome.
Yeah, I think it's important for patients to be involved in their care. Not a lot of them are. Not a lot of them have advocates, and I think if they can be their own advocate, making sure that things are done and their questions are being answered.
Mm-hmm.
Physicians or nursing staff or whoever is involved.
Yeah, I kind of imagine if I was able to text my doctor a question or go on the computer and download my lab results, that would imagine how involved they could be in my care and what that would feel like.
Yeah, I agree.
Mm-hmm.
Yeah, no, I totally agree. I actually read an interesting article just called Managing Health States for Chronic Disease. It was under Mobile Technology 2008 from a Nursing Standard Journal, but essentially what it said is, and this, obviously it only works with a certain group of patients, but now they're really doing real-time follow-up with complex critical patients with smart technology. So somebody with heart failure goes home and every day they just type in their weight, they type in their salt intake, everything is just automated and sent directly to the cardiologist so that they can eliminate and have a transitionalist or something go and follow up with them in the house so they can adjust diuretics, things like that, and eliminate reimbursement or readmissions. Obviously, it's all tied to money, and it's because reimbursements with these, you get hammered if it's under 30 days. So it's really cool. It works up, but obviously that's the problem is it only works for people of a certain socioeconomic status because so many people don't have phones or even access to the internet, and so and that's probably a large percentage of all the patients we see. So we have a lot of ways to work, but it's a great idea for a lot of people that have access to it.
Right, but the good thing is about it is with the aging population and the baby boomers, as the aging population keeps getting older, they'll have the technology, hopefully, more and more of them, so they'll be more efficient.
Yeah, I agree. So what are we thinking about this, now I'm somewhat lost, about a roundtable discussion?
I mean, I'm pretty sure, so this is how I interpreted it. We did a roundtable just now, but what I think, I think what we were maybe supposed to do with a real roundtable is just log on, say, I'm Joey, I'm an informatics nurse. You're whoever you want to be. And I kind of interpreted it as we were all just being informatics nurses, so I didn't really pick any other type of role. But we could do whatever you want, and then you just read your scenario, and we go around and we give our sources and citing and chime in when we want to, and then wrap it up when we're done.
So I feel like we did that then, right?
Yeah, it's pretty much doing it the same, like, from what I feel like, it's like redoing it, but then adding in that role, like, I'm such and such. And, yeah, so that kind of sucks. To have to redo it again, you know?
Yeah.
I don't know. I feel like maybe we haven't. You guys tell me. I feel like we've answered everything here. If we were role playing in a roundtable discussion, I don't know. If you guys want to choose a role and go through it again, we can. I don't know if we need to. Though.
I'll do whatever you tell me to do.
Hey,
Joey.
I will. I'm all for either, not going through it again and chalking it up to first time, and maybe emailing her and saying, hey, I think we worked out the kinks, or just going through it again. Yeah, whatever you feel more comfortable with. I don't want anyone to log off here and not be comfortable with what we're doing, though.
I feel comfortable with we've done it right now. And if we misinterpreted it incorrectly, I don't feel like it'll be a big deal. But I'm also totally fine to go through it again too. So
whatever.
I think it comes down to the potential of being deducted 4 points, as you said, right? Yeah.
There is a 4-point role play, like I said before.
This is role play informatics DRHA committee member. So
4 positive points.
So role play informatics, so basically, you'd have to be a member of this hospital's informatics team, answering these questions. So,
I feel like we answered them
which is what we did.
Before. Yeah.
I think we did.
Except we just didn't give ourselves a title in the beginning. Like, hi, my name is Cassandra. I'm a senior informatics team at what's this hospital's name, right? DH. Whatever.
Desert something.
So, oh my God.
I don't know. Whatever you guys want to do.
I feel like I don't think we would lose all 4 points.
You seem somewhat hesitant. Huh? I'm sorry? Go ahead.
Who? Me?
Huh?
Joey?
Yeah.
Oh,
no,
I
you.
didn't say anything.
Yeah.
Me?
Yeah.
Oh, no, I feel good. I'm okay to ending it. I just hope that everyone else feels okay with that.
Yeah. I do.
Yeah.
I think maybe we didn't go about it the exact correct way, but I feel like we've come a long way considering 3 days ago I didn't even know how to start a Hangout. So,
Oh,
Yeah, I agree.
I would say I still don't know how to start a Hangout. I know how to join a Hangout.
Well, that's just, I hear you. Okay.
All right, I say I feel good, but I'm willing if somebody doesn't feel okay to do whatever do whatever I can to make them feel okay. Monica, how do you feel?
I'm comfortable. I think we discussed the questions. Like you said, we didn't introduce ourselves as a DRHA, committee person, but I think we answered everything, so I think we're okay.
Okay,
Cool.
Joey.
I feel great
Okay.
about where we're ending.
Okay.
Okay.
All right.
All right.
Have
Well,
a
All
good day.
right.
Everybody enjoy the rest of their day. Thanks.
All right. Have a good week next week.
Thank you.
Bye.
Bye.